Hello everyone, this is Dr. Shrikant Patil, and as I had promised you all, we will be talking about hormones and infertility. Basically, we need to understand what is infertility. We can label a couple as infertility couple when they are trying for conception since at least 1 year of their marriage, and they are having regularly sexual intercourse, and if they are not able to get the results, then we will label them infertility. Again, what are the hormones? Hormones are the chemical secreted by glands to do its function. When we evaluate the infertility couple, we have found that 40% couple have male factor, around 40% couples have female factor, and almost 20% patient have got unexplained type of infertility. So first of all, we will see the male factors and the hormonal assay about the male infertility. So as we all know, males are very simple. So to start with the evaluation of infertility for the male, we have to first do examination of semen analysis, if required physical examination. Okay, we have to see if the semen analysis is normal, in physical examination if the testicular size is normal, and if we take the history whether there is any problem in sexual activity or any erectile dysfunction. We need to evaluate it because it has got relation with the hormones also. As we all know, if the semen analysis is normal, FSH, LH and testosterone will be normal. If the FSH is increased but LH is normal and testosterone is normal, then it is suggestive of spermatogenesis factor. If FSH is increased, LH is also increased, and if testosterone is decreased or it may be normal, then it is testicular failure. Again, if the FSH is low, LH is low, and testosterone is also low, then it is suggestive of hypogonadotropin hypogonadism. So basically, when we start evaluating male infertility, we need to evaluate the hypothalamo-pituitary testicular axis, which will have FSH, LH, testosterone, and if required, prolactin level. As I said, if FSH is normal, LH is normal, and the testicular size is also normal, and there is azoospermia, then it is suggestive of obstruction in pathway of semen. Okay, and for female infertility, we need to evaluate multiple hormones like FSH, LH, AMH, thyroid, TSH, inhibin A. So we will learn how to evaluate the hormones and what are their roles. So we'll study first the pituitary hormones, which are first gonadotropins. Gonadotropins are FSH and LH. So what is role of FSH? FSH, as its name suggests, follicle stimulating hormone. So it stimulates the follicle to get mature, which we call Graafian follicle. So for maturation of Graafian follicle, FSH is needed. It is also required for LH receptor synthesis. And when we see the levels of FSH in female body, we found that it start increasing just 1 to 2 days prior to menstruation, and the level are steady, almost steady, until the 12th day, after which it starts decreasing. Okay, so if we see the reports, every lab has got its different sensitivity, different report, different ranges, but in general, if the FSH is less than 10, it is normal. FSH less than 10 is considered normal. If it is around 15 or more than 15, we call ovarian failure, and when the value of FSH is more than 25, it is suggestive of menopause. The next hormone is LH, which is luteinization hormone. As its name suggests, it is important for luteinization or ovulation. So its values are static until before 12 hours of ovulation. So it is also useful in diagnosis of ovulation. The ovulation kit available in market are based on LH level only. Cut. If it is around 15 or more than 15, we call ovarian failure, and when the value of FSH is more than 25, it is suggestive of menopause. The next hormone is LH, which is luteinization hormone. As its name suggests, it is important for luteinization or ovulation. So its values are static until before 12 hours of ovulation. So it is also useful in diagnosis of ovulation. The ovulation kit available in market are based on LH level only. Next hormone is TSH, thyroid stimulating hormone, secreted by pituitary gland. So thyroid gland was supposed to be the monitor of all the glands. Then it is found that hypothalamus controls everything. But yes, thyroid has got its role in every aspect of menstruation, ovulation, all that thing. Also, hypothyroidism, both can cause infertility. So normal thyroid range, which is 0.5 to 5, or it depends, it varies lab to lab, but in general for fertility aspect, 0.5 to 5 is considered to be normal. If it is less than 0.5, it is hyperthyroidism. If it is more than 5, it is hypothyroidism. Both of them have a role in infertility. So before going for pregnancy, before going for infertility treatment, patient must check its her thyroid level, and it should be get corrected before going to pregnancy. Next pituitary hormone is prolactin. Abnormal prolactin level has got role in menstrual cycle and fertility. It has been found that increased prolactin level causes amenorrhea or scanty menses, anovulatory cycles, and main symptoms of increased prolactin is again two important hormones which give us idea about the ovarian pool, which are AMH and inhibin B. So AMH value considered to be normal when it is between 2 to 4. If the AMH level is less than 0.5, we call it as ovarian failure, and if it is more than 4, we call it as PCOD. And in the same way, the inhibin B value decreases when the ovarian pool is decreased. So decreased inhibin B suggestive of less amount of follicles remain in the ovary. Now most important part is how to prescribe the hormonal test and how to use hormones during the treatment of infertility. So what amount of investigations we need to do depends completely on the profile of the patient. Such as if the patient is young, then we can avoid doing AMH in the first visit because it is little bit costlier. So only FSH and LH level done on second or third day of the cycle are quite informative. Like if the FSH level is more than 10, then we have to think about ovarian failure. Then we will do the AMH level. If the FSH level is normal, then no need to directly jump on the conclusion of ovarian failure. So if we do FSH and LH on period second or third day, it is quite informative, it is sufficient. If the age group of patient is a little bit higher, like if it is around 35 or more than 35, then yes, definitely we can do AMH, FSH and LH on the first visit itself. The progesterone creates few body changes like increased body temperature, heaviness in breast, and mucosal changes in vagina, which are also important in diagnosing ovulation clinically. As we all know, progesterone supports the pregnancy, so its deficiency we call it as luteal phase defect. So progesterone is very important hormone for fertility. Cut. Increased prolactin causes amenorrhea, scanty menses, and important symptoms are galactorrhea, means milky secretions through nipples. So we can check prolactin at any day. It has got no specific role according to the menstrual cycle. It was supposed that prolactin level might get increased due to stress, or they may slightly get increased before the menstrual cycle. Or if you want to test the prolactin level, you should avoid per vaginal examination before going to do PV, because it might slightly affect the prolactin level. But you can do prolactin at any time. Good. Next hormones are ovarian hormones, out of which estrogen is important hormone. We call it main active part is estradiol. We call it E2. So androgen are converted into estradiol with the help of LH hormone, and its value is around 150 to 300 microgram. During ovulation it increases up to 300 to 600. So its role is creating secondary sexual character in female, like breast development, changes in vagina, uterus after menarche. So E2 causes negative feedback mechanism of FSH. So FSH level start dropping, and it causes positive feedback mechanism. So there is LH surge once the E2 level is increased. Next hormone is progesterone, which is produced by corpus luteum, as we all know. So as we know, corpus luteum and the progesterone is required for So hormones are used for therapeutic as well as diagnostic purpose. Like as I said, when we need to diagnose the ovarian reservoir or PCOD, we need to do FSH, LH, AMH, TSH, prolactin for diagnosing. And for treatment, many times we have to use FSH in form of injections for ovulation induction. So hormones are used in both the way, for diagnostic purpose, for treatment, for therapeutic purpose also. The most important part, the most chaotic part in infertility is PCOD. So जैसे मुन्ना भाई मूवी में दिखाया गया था कि केमिकल लोचा हो जाएगा तो सब प्रॉब्लम हो जाएगा, सेम PCOD is a chemical लोचा. So how to diagnose PCOD? With the help of hormones. As I said earlier, FSH, LH and AMH, these all will give us information about PCOD. As I said earlier, if FSH is in normal range but LH is raised, normal the ratio of FSH as to LH is 2:1, or the amount of LH should be half of the amount of FSH on say day 2 or day 3. So if the ratio is changed, then it is PCOD. If LH is more than FSH on day 2 or day 3 of cycle, it is called as PCOD. Suppose if FSH is 5, then LH should be ideally 2.5. If it is more than 5, if the ratio is changed, then it is called as PCOD. Again, the AMH level is informative about PCOD. If the AMH level is more than 4, it is called as PCOD. So